Welcome dear PG aspirants. Welcome to Ardent MDS. I am Dr. ANISH Poorna, Master Teacher in Ardent MDS. The topic that we are going to see today is an important one, distraction osteogenesis. Through your undergraduate period, you must not have or you may not have seen some of the cases of distraction osteogenesis, or you might have read only theoretically. So I will try to make it as simple as possible to make you better understand about the features of distraction osteogenesis, what are all the surgical procedures, and if you ask you a question on distraction osteogenesis, to make sure that you are answered to or you are able to answer the question properly. So from the name you can understand that distraction osteogenesis is nothing but a procedure where you are providing gradual traction. You are providing gradual traction to the bones, and that results in the genesis of genesis is nothing but formation of osteo, which is nothing but bone. So by this it means you are separating. So from the name itself you can understand that you are separating and providing gradual traction to the bone, and that results in the formation of new bone, that is known as distraction osteogenesis. So Eliza Rao, there is a person named Eliza Rao who studied on the distraction osteogenesis on long bones like femur and tibia, and he is known as the father of distraction osteogenesis. So what is the mechanism of distraction osteogenesis? It is mainly based on tension stress effect. So to understand distraction osteogenesis, you should know about Wolff's law. What is Wolff's law? We all know whenever a bone is put under stress, certain amount of stress, the trabecular pattern of the bone alters and the bone modifies itself according to the tension in that area. That is, whenever a functional burden is placed, the bone modifies itself, the trabecular pattern modifies itself according to that functional burden in that area, and that is the law behind the usage of distraction osteogenesis. The effect is known as tension stress effect. So that is about distraction osteogenesis. Eliza Rao is the father of distraction osteogenesis. So we know what is the mechanism behind distraction osteogenesis. Having known that, we will go to the surgical procedure of distraction osteogenesis straightly. So the first one, there are 5 principles of distraction osteogenesis. So this is all about distraction osteogenesis in a nutshell. So the first one is the surgical procedure. So what is the surgical procedure named in distraction osteogenesis? It is called corticotomy. It is not called osteotomy or some other thing, and it is called corticotomy because we are just fracturing the only one cortex of the bone that we are trying to move. So it is known as corticotomy. So what happens after that in the surgical field? We are placing the device and checking whether it is working properly. That is device application. And then what do? We have a period called latency period. What is latency period? It is nothing but waiting period. So the surgery for the patient is over today. So we have to wait for some days. We have to start distraction only after 5 or 7 days for the patient depending on the age. So that waiting period is actually known as latency period. It may vary between 3 to 7 days depending on the age. We will discuss that criteria in the coming slides. So next one is the activation period. So the activation period is nothing but we are starting to activate the instrument, that is the distraction device. So that is known as the activation period. It consists of rate and rhythm. How many times we activate, that is known as rhythm. How far it goes, it is known as rate. So next one is the consolidation. That is again the waiting period where we will wait for some time so that the bone is formed properly, and at last we remove the distraction device. That is the 5th principle. So there are totally 5 principles. It is nothing but initially we perform a surgery, we perform corticotomy, we wait, that is known as latency period, and again the 3rd step we activate, that is the purpose of the surgery, that is we start turning the device, that is when the distraction starts occurring. Next again we wait for some time, that is known as the consolidation period, and at last we remove, that is the 5th principle. That is simply the principles of distraction osteogenesis in a nutshell. So we will discuss in detail. So first, as I said earlier, we are performing only corticotomy, that is one cortex alone we are removed. Thereby, the endosteal continuity is preserved. So the main thing in distraction osteogenesis is that we have to say if the endosteal continuity is preserved. Then what happens? The internal milieu, that is the internal environment there present there, changes and gets modified, and it is conducive for distraction to happen. That is known as rotational osteoclasis. So this is the mechanism that takes place. So I told we perform a corticotomy. So this is a corticotomy. This is known as monovector. The corticotomy of this type is called as monovector because we are performing corticotomy on only one part, whereas this is known as bivector because two areas of corticotomy we are performing. And last one is known as multivector because it has the capacity to move in various planes. The multivector distraction is always a little bit complex because the machine is a little bit bulky and it is also complex. So what do we mean by monovector or bivector or multivector distraction osteogenesis? It is simple. Here we are performing only one osteotomy. Here, what is it? This is the vertical osteotomy. We are performing a vertical cut. That means we are performing a vertical osteotomy. So what will happen if we perform a vertical osteotomy? When we place a device, the mandible will move towards this side. See, it moves perpendicular to the osteotomy or the corticotomy that we have performed. When we put a vertical cut, it moves horizontally. When we put a horizontal cut, it will move vertically. So remember, whenever a patient is having reduced posterior facial height, be it any syndromes, for example, Perry-Robin syndrome or ankylosis, where the posterior facial height will be decreased, as we have discussed earlier in another session of ankylosis of temporomandibular joint. In those cases, the posterior facial height will be decreased. So what should we do? We have to increase the facial height. We have to increase the height of the ramus. So we have to increase the vertical height. In those cases, we will perform a horizontal osteotomy. So it is nothing. When we perform a horizontal osteotomy, the height will increase vertically, whereas when we perform a horizontal corticotomy, the horizontal dimension will increase. So what happens in bivector? So we want both horizontal also and vertical also. We perform bivector surgeries, that is by corticotomies. We perform corticotomies on two sides. Or oblique osteotomy, that is oblique corticotomy. If we perform oblique corticotomy, here it can move here also, this way also, it can move this way also. So this is all about corticotomy procedures. When we perform a multivector, when we use a multivector distraction device, we perform a single corticotomy but use a multivector device that can move in all the three planes. It is a little bit complex, so it is enough if you remember these alone. So we have seen about the vectors. So how do we plan the vectors? There's a simple formula for that. How do we place the pins on all the devices, distraction devices? This is a simple formula. We have to take 180 minus gonial angle. What is the gonial angle? This is the gonial angle, and the vertical deficiency. We will calculate how much is the vertical deficiency present, that is from the posterior facial height, and the total deficiency. This is the mandible. We will calculate the vertical deficiency and also the total deficiency, and we will arrive at a formula and arrive at a solution that 20 degrees. So for example, they have given an example that vertical deficiency is suppose 10 and the total deficiency is suppose 20. This remains the same. Gonial angle we have to measure from the patient. This is the gonial angle. We will measure. Suppose it is 140. We will get a solution like 20 degrees. So this is the formula that we use for vector planning that you have to memorize. So next, this corticotomy step is over. That is the first surgical procedure. First principle of distraction osteogenesis is over. As I said, after performing surgery, suppose today the patient has been performed surgery, what should we do? We have to wait for some days. That is the latency period. So why do we actually wait? We wait because we wait for the fibrovascular bridge to develop. Actually, what happens during the latency period is we have performed a corticotomy, the hematoma, all the blood vessels and all the organization will occur, and there occurs the formation of fibrovascular bridge. So the fibrovascular bridge has to occur. What happens if we start the activation of the device immediately after corticotomy? There will be no fibrovascular bridge, and after that it will become a dead bone. So what will happen if we wait for a longer period? if we wait for a longer period, the fibrovascular bridge will become a bone, then it will become ankylosed or it will fuse together. So if the latency period is so much increased, we saw it is usually between 5 to 7 days, because it is the time interval between the initial surgical procedure, that is the corticotomy, and the device activation. That is the next principle, when we start activating the device. So that is the latency period where we wait for fibrovascular bridge. When the latency period increases beyond 5 to 7 days, it goes for fusion, and then even if we activate, the traction will not occur. So when it decreases, if it is very less, or if we start activating immediately, there is no bridge, there is no development of fibrovascular bridge. So this is the importance about latency period. So it varies, as I said. In children we need to wait only for 2 to 3 days, because by that time itself the fibrovascular bridge will be formed, whereas in neonates the healing is excellent, and that way we need not even wait, we can start activation the same day itself. And next, for elderly patient we have to wait for more than, like the usual period I told is 5 to 7, we have to wait for more than 7 days, that is for 7 to 10 days, because of the healing capacity. So the next principle is activation, that is the waiting period is over. The third principle we have come. Next, after 1 week we have operated a patient and kept in the latency period. Now after 1 week is over, we have to start activating. That is where we are actually starting the traction. So what happens is, I told you about the rate and rhythm. How many times we activate, that is known as rhythm. So the rate of distraction is usually 1 millimeter per day, and it will be usually divided, and just like we give a dosage of antibiotics QAD or BAD, we will do it QAD or BAD, that is 2 or 3 times a day, depending upon again the age factor. That is how we activate. So the two factors are rate and rhythm. So next one is last, again the waiting period. We have to wait for some time. What happens here? Whatever the fibrovascular bridge that has been formed, that will start fusing, and slowly the bone formation will happen. So that has to become established. So what happens here actually in consolidation is, it is the time for the completion of distraction and removal of distraction device. Between the third principle and the fifth principle comes the consolidation. So that time period is known as consolidation. That is also known as period of neutral fixation, because we do not do anything during this period, and it is twice that of activation period. What is activation period? We saw when we start turning the device or using the device. Suppose we use the device and keep on distracting to the desired amount for around 1 month, we keep activating. Then we have to wait for 2 months for consolidation. That is, the bone becomes consolidated, the bridge becomes consolidated. So this is a schematic representation that I have put. Here we are first initially doing a corticotomy, or some cases we go for osteotomy also, and then we go for latency period. That is, we will wait for some time, and thereby the fibrovascular bridge forms. Then we start activating. That is where we play the screw that has been placed, pin that has been placed. We start slowly traction, and there occurs the radial and sclerotic zones, or the bone formation slowly starts happening, and the new blood vessels and the arise and trabecular pattern also changes when we wait again during the consolidation period. What is the main advantage of distraction osteogenesis is, we are moving the bone actually, but the soft tissues also get adapted to the formation or moving of the bone. That is one important advantage of distraction osteogenesis. So these are all the principles of distraction osteogenesis. So when we see in a histological picture, we actually see these are all the zones of distraction osteogenesis. In the center, as I told earlier, we have fibrous zone. So this zone is the fibrous vascular bridge. So this is the fibrous zone, whereas the second one is the transition zone. This last one is the mature bone. So here lies the fibrovascular bridge, and here lies the bone. So in between there is transition, and here occurs remodeling. So these are all the zones of distraction osteogenesis that you can see. So put in a nutshell, all the principles that we have seen along with the timeline, this is a very important one that you have to memorize. For example, in neonates, I told the latency period is 0. That is, on the same day itself you can start activating. The total rate, this is the activation rate and rhythm. You do 2 or 3 or 4, even 4 times. For neonates, it is around 2 to 4 millimeters per day. You can even move up to 4 millimeters. Whereas in elderly, it is around only 1 millimeter maximum you can move. If you move beyond that, the healing is not very good in case of elderly, and that is why the rate is also less, and then the consolidation period is very less. Why consolidation period is very less? Because the activation is faster. That is, we start activating and we achieve the desired result very soon, and it is only 2 weeks. Whereas for adults, elderly, the latency period is very high, 7 to 10 weeks, and then 7 to 10 days, and then for consolidation period again we have to wait for around 3 months. So this is about distraction osteogenesis. So coming to the advantages and disadvantages. Advantages is you can get good results. The soft tissue is also moving along with it. What are all the disadvantages? Like multi-vector movement, if you do, the patient will be having a device here outside and it is sometimes cumbersome. So we will see about the types. These are all the types of distraction devices that we are going to see. One is with relation to the skin. It can be placed either externally or internally. That is, if you place it extraorally, it is external. If you place it intraorally, it is internal. And then depending on the anchorage device, derives, it is either bone-bone or tooth-bone or including both. It is called hybrid. And number of vectors we already saw, depending on the corticotomy also, it is monovector, bivector or multiplanar or multivector. So we all learned about distraction osteogenesis. If you don't see any picture about that, you will not understand anything. So this is how you perform. See, I told you earlier, here we have performed a horizontal osteotomy. Okay, we are performing a horizontal osteotomy. That way we are placing the distraction device, upper port, lower bone plate. These are called the upper and lower bone plates. And what happens is when we turn the device, the vertical height increases. This height actually increases. So this is the advantage and this is the device that we use. So next, as I told earlier, these are all the bone plates that we have, and this is known as alveolar distraction. Alveolar distraction osteogenesis, where we augment the ridge with the help of distraction osteogenesis. So if they show a picture of this is known as alveolar distraction. So next one, this is again the upper plate, lower plate, and this is the activation port. And this is how you keep an intraoral. Like for example, the patient is having total mid-face hypoplasia. That is, the mid-face is totally inside. Then you have to keep pull the maxilla outwards. You will go for maxillary distraction osteogenesis. So the next one, these are all the hybrid one. This is the external device where the patient is having a halo frame. That is a frame kept here, and this is an external device. Whereas this is an internal device. And this is an important another topic that we have discussed in detail in TMJ ankylosis about the formation of neocondyle with the help of distraction osteogenesis. What we do here, we place an inverted L osteotomy. This is L, inverted L osteotomy we place, and we put an instrument device here, distraction device, and we start activating it. What happens here? The condyle, this bone slowly moves upwards and forms a condyle that is known as neocondyle. So this is about bone transport in distraction osteogenesis for TMJ reconstruction. So this is again another picture of distraction osteogenesis in case of infants. This is the pins that you can use for activation. And at last, this is a picture of Peary-Robin sequence where the patient is having retrognathia. See, the patient's mandible is positioned very backward. What you are going to do? You are going to horizontally increase or put the mandible forward. So what you will do in this case, suppose a patient like this comes, you will perform the surgery first. What do? You perform a corticotomy first. And how long do you wait? What is the latency period? You can start immediately. That is, the latency period is 0 in case of neonates. Okay, so in latency is 0, you start activating and you will get the desired result immediately. So this is all about distraction osteogenesis in a nutshell. I hope you have understood the principles of distraction osteogenesis, how the surgical procedure is taken place and what are all the steps you follow after the surgery is over, and the time frame according to each principle, and the last principle is the removal of the device. So everything we have seen in a nutshell, and I have also shown you some pictures, the external and the intraoral devices, and how you put up a monovector, bivector or a multiplanar device. So these are all in a nutshell of distraction osteogenesis. Hope you have understood everything and you will be able to answer any question they ask you on distraction osteogenesis. So have happy learning and a thorough concept oriented learning. Thank you.